Done. No, I've not done this right. Sorry, I'm always bad at this. Hold on. Right. It should be it. So, can you see my title screen without my notes? Yeah? Okay, great. So, magandang umaga for inviting me here today to speak to all of you. Mum Joyce forgot to say that I did actually live in Manila for about 18 months back in 1998, 1999. And that's where I met Mum Joyce, and I worked at UP Camp on the master's program, and had a fabulous time working with the students there. Really enjoyed it very, very much. And I lived in Mandaluyong, but outside, not inside. And I wanted to ask you guys, one of my strongest memories of Manila was the traffic. Has it improved any? Or is it still bad? Yeah, still bad. Oh, they were building the metro while I was there, and that was supposed to solve all the traffic problems. It hasn't?
It's a bit better.
Yeah.
Yeah,
But
but
I have,
they started building another skyway and then another. Wait, it's been better the past year and a half just because no one's on the road because of the
COVID. Right. Yeah, but I have to say that it's made me, wherever I go else in the world, when people talk about traffic, I'm like, ha, this isn't traffic. Here in Greensboro, where I live, if there are 8 cars at the traffic lights, oh, people say it's bad traffic. And I'm like, there's only 8 cars here. If it takes us more than 20 minutes to get anywhere in the city, it's like, oh, it's really busy today. It's a small city, very easy to get around. So as I go through my presentation, please feel free to stop me and to ask questions as I go along. Now, it's difficult with the screen to be able to see all of you when I'm talking, so please just unmute yourself and say, excuse me, I have a question. So don't be afraid to stop me and ask a question, because there's a lot of material here, and there's a lot to get through. So please, yeah, feel free to stop me whenever you wish. So I'm going to talk through a presentation that I gave at ASHA in November 2021 on the capacity pyramid. And it's about how audiologists and speech and language pathologists can be involved in developing a population-based approach to service delivery, and how we can maybe reimagine ways of providing rehabilitation and therapy to people experiencing communication disorders. So Onyi, Richard, and myself, we're 3 professionals who have pooled our knowledge and experience to develop just one way of looking at tackling the issue of building capacity for audiology and speech pathology. We did this mainly looking at sub-Saharan Africa, because that's where the bulk of our experience was, because I lived for 11 years in Uganda, Richard 13, and Onyi is from Nigeria. So the majority of our experience has been in sub-Saharan Africa. And so this is us. So Onyi was born in Nigeria, where she qualified as an ENT surgeon, and then she studied for her master's in England and her PhD here in Greensboro with me. That's how I met her. She's also an audiologist as well as an ENT surgeon. Richard's from London, and he has a PhD in operational research, and he's worked in international development for over 30 years, with 13 years in Uganda, where he was the executive director of the Infectious Diseases Institute. So he specializes in institutional development, knows very little about speech pathology. But I have to admit here that actually Richard is my husband. Um, we've been working together now since I've been doing my PhD. We've realized that my area has shifted, of interest has shifted, and his has shifted a bit. So we've moved more together on some of our thinking and some of our approaches. So we've been doing a lot of work together, and we work together on this project. So as I say to Mam Joyce, I'm a speech and language therapist. I was born in India, but educated in England, and I've worked in England.
I have to say that when Maurice was living here, the security guards at in the building where she lived couldn't pronounce Richard's last name, so they would call him Mr. Fernandes.
Yeah, they couldn't say bruff. Very difficult to say. So he was always known as Mr. Fernandes, which I really liked, and he actually quite liked it. When we got married, I tried to persuade him to change his name to Fernandes, but he decided that he was too old-fashioned. So I've worked in England, Fiji, the Philippines, India, and Uganda. And yeah, now I'm studying for my PhD here at UNCG. And while it's a PhD in communication science and disorders, my minor is in public health. And it's really becoming my major. I'm really focusing more and more on public health approaches and less on actual speech and language therapy and rehabilitation. But I'm trying to marry the two together. So in summing up, I tend to say that my passport, my accent, my education, and my husband are all English, but I'm from India. So I'm going to talk today about the genesis of the project, then about the aims, the problem, and some suggested solutions. I'm going to talk briefly about 4 public health models that we feel are really important to know about. We'll touch on 2 briefly, but then concentrate on 2 in more detail, which will be the socio-ecological model and the capacity pyramid. Hopefully there'll be time for discussion and answering questions and talking about how this applies to you in the Philippines. So as I said, please ask questions as we go along. So this presentation, it's the culmination of all of our years working in sub-Saharan Africa and other low and middle income countries, and the frustrations that the 3 of us have experienced with our work and the work of others, and the slow wheels of government and the lack of sustainable inputs when developing speech and language therapy and audiology services. Beginning my PhD, it's been a real phase of enlightenment for me, where I've had time to reflect and to think critically about ideas, experiences, and where I've learned about public health theories and approaches, some of which I was using and I had experienced before, but I hadn't realized that they were proper public health theories or public health models. So this picture here is of the Sankofa bird. It's a mythical creature from West Africa. And if you look at it, it's a bird flying forward, but looking backwards, while protecting an egg that it's holding in its mouth. And it symbolizes the need to acknowledge and remember the treasure, the gems of knowledge from the past and the old ways, while also looking to the future and embracing the new. And it reminds me of the benefit of combining the old and the new, the African and the Eurocentric knowledge, and the ways to produce that works best to and for the people of sub-Saharan Africa experiencing communication disability. And I can see similarities with the Philippines, where the American ways are the new ways that have been very much embraced by the Filipino people. But there's also the old ways that you used to do things in the Philippines, and that you mustn't forget those. So you must remember the old and embrace the new, and combine them. And we're not inventing anything new here. We're just recycling the old and representing it in a new format. This presentation is an accumulation of all that we've read, we've experienced, and we've learned from others along our journey. And they've kindly shared their knowledge and wisdom with us. And so now I'm going to try and share some of that with you. So the questions I'm hoping to address are, why is there a need to employ public health population-based approach in sub-Saharan Africa or here in the Philippines? And how can we apply the socio-ecological model and the capacity pyramid when planning and developing services for people experiencing communication disorders? And Jean, you said it, that the demand is outstripping the supply. So what can we do about that? How can we try and address that problem of more demand and less supply? And then also we'll look at why is the capacity pyramid a useful tool that can help us to do just that. So if we look at the statistics, we can see that 15% of the global population live with disability and 50% live with a communication impairment. 80% of people living with disabilities are in low and middle income countries. 60% of the population of sub-Saharan Africa live in rural areas. And I'm sure there's a large population in the Philippines that live in the rural areas and outside the metro areas. There's one audiologist per 800,000 people in sub-Saharan Africa and one speech and language therapist per 1.3 million. That's a huge caseload, if you think about it. And I'm sure some of those statistics are probably very similar in the Philippines as well. I don't know if you know the actual percentages and the breakdown of therapists to patients in the Philippines. Anybody got any idea? Has it been worked out? Is there any data on that yet? No? Okay, that'll be an interesting thing to calculate at some point. And so we can see that the medical institutional model that's been used, it's very difficult to achieve that in LMICs when we have huge rural areas and poor infrastructure. So if we look at the problem in terms of statistics, that speaks loud and clear. And from this, I think we can see that that medical model that's employed, it's not adequate to meet that demand. And I know that in Manila, you've been looking at a CBR approach, at least in Metro Manila, which is great. Have you had any experience of the CBR program, any of you yet? Yeah? And what did you think of it? How did you find it?
The community's community service program that we mentioned before, that was the CBR. That was our rotation prior to this one, and we all worked in different service programs. I will admit it was a little different from the previous experiences of older batches ahead of us, because we mostly worked with organizations CBR is affiliated with. So me and Ishi were working with Kaisaka, that's an associate organization of parents, and we were tasked with developing sort of promotional material. We were editing videos to introduce where the group came from, what they're about, and that's where hello Martin. Martin, that was what he mentioned, the wheelchair manuals, if I'm not mistaken. The others can talk if they want.
Do you think it was a good model? Did you enjoy going out into the community and working in the communities as opposed to maybe being in a clinic, in a hospital, or in a health center? Yeah.
It was certainly different, and it really gave us a chance to work with the community itself, because it was in the clinical practice. It's mostly you're considered a professional. However, in CBR, we are mostly looking to collaborate or work together and really look for their insights on the projects that we were doing. So yes, it was really insightful.
Great, another perfect answer, and that will come up again later on in the presentation, so thank you. So looking at the literature on a class that I took on culturally responsive research, I came up with these quotes that kind of summed up the problem in terms of the colonial legacy and inheritance. And in the Philippines too, you are a country that's been colonized by the British and the Spanish and the Americans almost So there are similarities, with the Philippines and sub-Saharan Africa. So we can see that, the departing colonial powers left behind urban-based, costly specialist healthcare systems that were modeled on their systems that they had in their countries. And the medical model, it's resource intensive and it's reliant on efficient and trusted institutions, both of which are difficult to achieve in LMICs, where we have a large rural population, where resources are limited, and where infrastructure and institutions are often weak. And the importation of the Western epistemologies is evidence in the education and the health institutions in LMICs. And over time, it's proved to be inadequate for tackling the health inequities in sub-Saharan Africa. And when we talked about this, Onyi had a very interesting experience. So Onyi grew up in Nigeria and she went to school and university in Nigeria. And she said that once she took this class, she said she realized that she was a product of a Western colonial education, that the way she'd been taught, she was looking at Nigeria and the people there through a Western, oops, sorry, I don't know. 1 second, I'm sorry, I just need to take this. Hold on. Sorry. Hey, I'm in the middle of teaching a class, what's up? Okay, hold on just 1 second. Can you call Papa? Thanks, bye. Sorry about that. That's my daughter. She's at a rehearsal practice. It's their final rehearsal before their production tonight. And she needs a lift. So I will not be going to pick her up. Richard can do that. So what were we saying? What was I saying? Yes, I was talking about Onyi and her experience. And so she said that she suddenly realized that when she was working with her patients in the clinic, she was expecting them to turn up on time. She was expecting them to buy all the medicines she prescribed and to take them all regularly and to come back for appointments and just, to do whatever, she said or advised. And she realized that she was really out of touch with the villages in Nigeria, and that she was looking at things through a Western lens and had forgotten about the Nigerian way of doing things, the Nigerian approach and the Nigerian culture when it came to care and rehabilitation and medicine. And that was all because of her education. So it's really important to still to go out into the communities and to not forget that. And I think, at UP, there might have been a time where very much you were being educated in the American approach to speech and language pathology. But I think, that's really changed a lot now. And, I don't know, Joyce, you could probably speak to that more, how things maybe have changed and how you're going back to the Filipino ways and the Filipino approaches and the Filipino ways of working with the clients and with the people that you have and getting back in touch with that cultural side of things.
Yeah, I would say the basic frameworks are still, we're still using American textbooks and American journals, but there's a very deliberate effort to develop Filipino norms for communication, and we haven't really gone into what is communication in the Philippine context, because I think it's quite different from what communication is in an American context. But there's also much more consciousness about looking for or looking to how much does this really apply in our setting. So in teaching, the students are not expected to swallow whole whatever is in the references. There's always okay, let's look at this, what applies for us and what doesn't, what might we need to change. And a lot of development of materials that are language specific, culture specific. Not a lot of it, in the boom cards, there's a lot that's accessible to whoever has access to boom cards, but we don't have a lot of published material or tests or therapy materials beyond that. Do you use boom cards? Have you heard of them? It's one of these online applications for use for teletherapy. And the developers really made it possible to create materials in different languages for different cultural groups.
Yeah, when I was in Kampala, we had two students come out. One was my niece, and one was a colleague's son from England. And they came out and they took photographs and made drawings, black and white line drawings of bowls and cups and spoons and different verbs and fruits and vegetables, of everything Ugandan, so that we could use, you know, Ugandan appropriate materials instead of using pictures of this wonderfully perfectly shaped and coloured and photographed fruit and vegetables from the UK or America. So, you know, you could see the durian, or you could see whatever it was, the jackfruit, or, you know, they had more appropriate resources, and they had people that looked like them. You know, they had all those action verbs with actual Ugandan people, and instead of, you know, washing up in a sink in a kitchen, perfect kitchen washing up, you know, they would be washing up with a bowl outside in the garden, you know, using the materials that Ugandans would use to wash up their plates. And so it was just much more accessible to the people. What they were seeing was things that they could really identify with and could talk about.
There's a really nice set of materials that was developed by a camp graduate, but she's Indonesian and working in Indonesia. And it's a full color packet of Indonesian people, individual, one person doing one action, which lends it very nicely to both artic and language, pediatric and aphasia. And since Indonesia's circumstances are very similar to ours, it's quite applicable to this setting, except that the words on the back are in Bahasa.
Okay, so we can see from this literature that this isn't a new problem. It's been a problem for a while, and it is across the world. So if we just very briefly, in sub-Saharan Africa, we've got audiology programs in South Africa, Kenya, and Ghana. We've got SLP programs in South Africa, Kenya, Ghana, and Togo. Togo's French speaking, and they're preparing to start programs in Rwanda, Zambia, Tanzania, and now Ethiopia. So how many programs do you have in the Philippines? Is it just the one in Manila, or you've got 4 now? Ooh, where? Where are your 4 programs?
Can you tell her? Can you sabi?
4 universities are already offering the program po. One is in Visayas, in Cebu Doctors University, and the other 3 are here in Luzon. One is in Cavite po. It's in Region 4, in De La Salle, HSI, and then the other one is also here in Manila. It's in UST and along España po.
Oh, wow. Excellent. Very good. So then what's the intake? So each year, how many are graduating?
30 to 60 students.
30 to 60 students each year.
Okay. I think UST recently increased to 60. They were 30 a year. I think LaSalle has always been 30 a year. Tama ba? Anong alam niya?
Lot. That's great.
Yeah, so instead of graduating only 30 students a year, now we're graduating maybe 180 more. Yeah.
Great.
It's fabulous. And the ones in Cebu speak Cebuano.
Excellent.
And they're working in Mindanao, and they're working in the nearby islands that also use Cebuano.
Okay, so we can see that in sub-Saharan Africa, at least, it's just not working. Or it's not working as well as we and people who are experiencing a communication disorder would like. And we all know this, the therapists here, the therapists in sub-Saharan Africa, and that we know that there are systems challenges that need systems resolutions. There's a lack of resources, which is staff and materials. There's accessibility problems, looking at the numbers of clinicians and especially the numbers in the rural areas. There's affordability issues. Many SLTs in sub-Saharan Africa are working privately or with NGOs, and services are often not free outside the capital cities, which I suspect is very similar in the Philippines. Away from the big cities and on the smaller islands, there's probably little or no speech and language therapy services, I'm guessing. So the current service provision is not sustainable because it hasn't really been strategically planned with all the stakeholders and the government together. Not even in sub-Saharan Africa have they got a strategic approach to providing speech and language pathology. So these problems are very widely reported, but what can be done? So also from our readings, these extracts identify solutions that have been proposed over the years, time and again. Successful health interventions in low and middle income countries and marginalized communities are best when based on a community health model or a social model of health delivery. SLPs and audiologists need to broaden their scope of practice to include alternative approaches to service delivery for people experiencing communication disorders in order to reach the underserved in those hard to reach rural areas. And lastly, solutions need to be grounded in public health principles and not just a medical rehabilitation approach. So this is why I'm moving more into public health and population-based approaches, because I feel that just the medical rehabilitation approach is that we're not seeing enough, we're not reaching enough people. So if we have two examples here to illustrate that point of alternative service delivery. So first, if we think about hearing loss prevention by education in the community. So 60% of cases can be prevented by educating mothers in safe pregnancy practices and management of childhood ear infections. Now, this doesn't need to be done by expensive, fully trained audiologists or ENT consultants. We could have community health workers or nurses. They could all be trained to impart this information at a hugely reduced cost. And if we look at, in the SLP world, looking at dysphagia services, hiring 2 dysphagia specialists in a big, well-equipped city hospital offering the gold standard in assessments, with all the modern equipment and instrumentation, they would see probably 20 patients a day. Now that would be a very, very busy day, versus for exactly the same cost, employing 200 community rehabilitation workers, and between them, they could see 1,000 patients a day. So you can see how the numbers speak for themselves. I've done both. In Fiji, I trained community workers, and in Uganda, I set up a multidisciplinary team in a city hospital. Now, I think that both have their place, but I feel that from the service user point of view in sub-Saharan Africa, the community provision is preferable over and it's more economical for everyone. So when you are out in the communities with your community projects, could you see the difference in that, having the community approach and then having the approach where clients came to you in the hospital? Did you see how the two experiences and services are very different? But they're both, they're both important and they're both needed. But it's which one do we develop first, or do we develop both in tandem? We'll again look at that. So really what we're saying is that we need a new approach, one from a global health perspective. And if we look at the Sustainable Development Goals, have they talked about Sustainable Development Goals yet, Ms. Joyce? Yeah, you briefly touched on them.
Well, not with me. Where did you address the Sustainable Development Goals? Within the articles that we went over, or?
Undergrad years, ma'am, with OPSD courses.
Okay, so they've taken it up in other subjects, yes.
Okay, so you know what I mean by the SDGs. So really, we could look at SDGs 1, 3, 4, 8, and 10. No poverty, good health and well-being, quality education, decent work and economic growth, and reduced inequalities. And speech and language pathologists are really working towards all of those goals. And by working towards those, we could enable everyone in LMICs and in high-income countries too to access audiology and speech pathology services as part of universal health coverage. And to achieve this, we need a fresh, strategic and practical approach to delivering the services. So if we think about the knowledge and skills needed by speech and language pathologists working in LMICs, local and expatriate professionals alike, they need skills, but they also need clinical skills that are more generalist rather than specialists, as specialism is a luxury. They need to be creative and critical thinkers and problem solvers. They need to be able to teach and train and share their skills and knowledge. And they need to be able to build trust in the community and work together with the community. They need to have humility in the area of cultural and linguistic diversity. They need to be able to collect, analyze, and disseminate data, be it at a clinical audit or a research level, to be able to produce evidence in support of proposals being made to policymakers and funders. So basically, we have to be supermen and superwomen and do all of these things. It's a lot, but it's really important to have lots of generalist skills rather than just focusing in on one. So now switching to those public health models that I mentioned. So in our work and in our studies, we've been exposed to many models of public health approaches to service delivery. And there isn't time to mention all of them. And several of them have come out of LMICs. And I wanted to briefly mention two. And I encourage you to read more about those yourselves. So the first is from Mershon Pillay and Harsha Cathard, their EPIC model, which calls for radical rethinking for providing equitable population-based innovations for people experiencing communication and swallowing disorders. Now, Mershon and Harsha are from South Africa, and actually Mershon's on my PhD committee. And actually, I must send you a link on Monday. Remind me, Mum Joyce, he's doing with Reading University, he's doing a webinar on decolonizing education in higher income institutions.
What time will it be?
Sorry?
What time will it be?
It's going to be at 2:30 p.m. my time, so it's the middle of the night your time. But they might record it. I don't know, they might record it. So I'll send it to you anyway. And if any of you are feeling like you can lose sleep for one night, you can. But yeah, I'll send it through and it'll be very interesting. And then the second model is,
so it's going to be Sunday for us. Yeah.
yes.
Where is he based?
No. So he's actually in New Zealand at the moment, but he's doing
so it's going to be
Reading.
in the middle of the night for him.
Yeah, yeah. So it's going to be 6:30 p.m. UK time. So 2:30 p.m. our time, and yeah, it's going to be the middle of the night or early morning for Mershon. But that was the way you could find it. But I'll send you those details. And the second one is by Karen Wiley, who's from Australia, who spent many years in West Africa in Ghana. And her PhD thesis was looking at service delivery for people experiencing communication disability in sub-Saharan Africa. And her model, it's in her summary of her lit review, and she advocates for the need for a population-based approach using a multi-sectoral network of services in the community to improve equity of services and to promote change at all levels of the socio-ecological model. And in her own words, she says, engendering change of this nature may mean that the profession of SLT shifts away from the replication of Eurocentric approaches to create Afrocentric forms of communication disabilitation rehabilitation, which responds to the needs of both the community and individuals in culturally and contextually responsive ways. So she's really trying to tell us to not think narrowly, to think broadly, and not just focus on what they're doing in Europe and what they're doing in America, and think about what's right for the Philippines, what's going to work for you, and what's going to work for the people that you serve, and think about your culture and your context, and be responsive to those. And there are many other models like the community-based participatory approach, the precede-proceed model. There are lots of them, but today we're going to focus on two that we consider important, and one is the socio-ecological model, and one is the capacity pyramid. So have any of you come across Bronfenbrenner's socio-ecological model? Yes? It's something that I know they use in education. It wasn't mentioned when I was training, and I really wish that it has been. But Bronfenbrenner's, so Bronfenbrenner's socio-ecological model is generally well known, and it's very, very much cited. And it was Bronfenbrenner that was the inspiration behind some huge programs in the US called Head Start, which was a preschool early intervention program. He described child development in terms of the relationships, influences, policies, resources, and the environment of the child, i.e. he was keen to look at the whole child and to look at prevention rather than rehabilitation. There are many socio-ecological models that are used in health, in education, and in the private sector, but they're all based on Bronfenbrenner's. Now, this is one that we drew up and that we developed for looking at speech, language, and hearing in sub-Saharan Africa, and it's based on McElroy's model. So at the heart of the model, and it's all color-coded, and these colors are important because they'll link in to the capacity pyramid that I'm talking about later. So at the heart of the model is the individual experiencing the communication disability. And if it's a child, it actually includes their caregivers with their attitudes, their beliefs, their knowledge, and their behaviors. So we're talking about each child and their caregiver. They have different attitudes, different beliefs, different knowledge, and different behaviors. And you need to consider all of those each time when you're working with someone. And then the next level is the interactions that these individuals have with their family and their friends and their social networks. And then we go a little bit wider and we bring in the organizations that those individuals interact with, like their school, their employer, the faith-based institutions they go to, the churches, the mosques, the synagogues, then the local businesses like the shops, the restaurants, and the banks that they go to. So we need to consider the person who they interact with, the organizations that they're using, and then we look at the blue circle, which is the policy level, where the policymakers and the lawmakers are positioned, that make laws and they make policies in health, in education, in social welfare, that affect the organizations and the people. And then all important to me is the communication and the relationships between all of these levels, which is the purple circle. And it's really important to have communication in all directions. And then finally, we've got the red ellipse that encompasses all of those circles. And to me, it's especially important to remember when you're dealing with minorities in the Philippines, in America, or in sub-Saharan Africa, especially if you're an outsider to that local context and culture. And it's the culture of all the people involved, not just the client at the center and you at the outside. The model highlights the need for community-based participatory approaches, where there's consultation and collaboration, and above all, communication between all the levels in the model. And the model's not unidirectional. It's not just from the inside towards the outside. Think of it more as a three-dimensional globe in which each level is a sphere and there are interactions in all directions. Does that make sense to you? Do you understand, what that's about? It's about a holistic approach. It's about community participation, all of the stakeholders being involved. Any questions about that? No? Okay, let's go on to the next one. So today I really want to focus on Potter and Bruff's capacity pyramid, and that emphasizes a strategic approach to developing services and actually incorporates many aspects of the other models that I mentioned. And the colors here show how it aligns with the socio-ecological model. You can see the green, the blue, the red, and the purple. The pyramid was originally published in 2004, and it's been heavily cited, including by WHO. And this is an adaptation of that we're going to look at an adaptation of the 2004 model that was in the original article. And it didn't have this lowest level, level 1, the understanding of local culture and context as part of a global system. After more reflection and working, Richard added that level to the pyramid, which I think is the most important level of the pyramid. So when we talk about capacity, what do we mean? What do you understand by the term capacity? You know, when we talk about strengthening capacity, building capacity, what do you understand by that? Is it a term you've heard? Is it a term you've come across? In what
No,
context? Where have you heard it?
capacity building, maybe within like seminars for skill building, skill capacity building. But from what I understand, or what I can, how I can describe it, is what you're able to do with the resources that you have, perhaps.
Yes, and often capacity is, when people talk about capacity, they often talk about skills training, empowering, giving the individual more tools, more resources to deal, or how to use those things better. But when we talk about capacity, we're talking about more than training, more than providing people with just skills and equipment. And we certainly need to develop the capacity of individuals and ensure that they have the skills and resources to do their job properly. But we also need to strengthen the capacity of the organizations in which those individuals work. So there's personal capacity, and then there's organizational capacity. And it's important to recognize those two and to work at both levels of capacity strengthening. So how can we do that? Well, we think that, like all complex systems, it needs to be broken down into manageable, bite-sized chunks. And we feel this is where the capacity pyramid can help with that. When looking at the capacity in any organization or setting, we can develop, build, and strengthen capacity by supplying tools, by providing training to strengthen skills and change attitudes, by expanding staff and infrastructure, by reorganizing structures, by redefining roles and modernizing systems, and hopefully doing all of this while paying attention to the local context and culture at every stage in the process. The capacity pyramid provides a framework for thinking these things through, and it promotes communication among those grappling with the problem. And it can also help when seeking funds. You can use it to develop grant proposals. And it's not top-down or bottom-up model, but for ease of explanation, we're going to look at it from the base upwards. But yeah, it's not, you don't always have to do that. So the base we're calling level 1, and we can see that by paying, and we're going to go through each level in turn as we go through the presentation. So the base that we're calling it level 1, we can see that by paying thorough attention to the local culture and context, and having an understanding of global trends and systems, this may enable more effective creation or reorganization of those structures and those roles and those systems which are at the next level. And these enable more effective use of staff and infrastructure at level 3. And at level 4, the training provided to the staff by the educational establishments and managers, which are actually in level 2, that ensures that staff have the required knowledge, skills, and attitudes to perform their duties efficiently, enabling them to effectively use tools and resources at level 5. But if we start at the top of the pyramid at level 5 and we descend, we can see that the resources or tools provided require skilled staff to use them. And those staff require that there be enough staff who need to be supported by adequate infrastructure, which can only work if there are robust systems in place with well-defined roles that have been developed in collaboration with the community, and that there's a clear understanding of the local context and culture where this is all happening. And that brings us back down to level 1. So each level is connected to the other level, and you can go up and you can go down the pyramid. All right, it's not unidirectional, it's bidirectional. So the pyramid provides a checklist to identify the gaps which need to be addressed. And equally importantly, it's a communication tool so that everyone can see what needs to be thought about and resolved, or if it can't be resolved, just accepted, when making plans to build the capacity of the individuals and in the organizations in which they work. And it really is important to remember that the pyramid is not top down or bottom up. You can work at any level depending on your resources and your context. But when you're planning, it's important to consider all the levels. Okay, so what we really need to avoid is unsustainable services. The easy option is to provide resources and training at the top of the pyramid, which is exactly what I was involved with when I was sent to Fiji back in 1993. So I was sent out as a volunteer to Fiji, and I was feeling very confident as I went out. I'd received training from Communication Therapy International that taught me all about how not to reinvent the wheel, how to be culturally sensitive, how to have cultural humility, how to make sure that you built on existing systems and structures and didn't try to bring in new things without building up what was already there. And I'd spoken to 3 of the volunteers who'd been in Fiji before me, so I understood the local context, I'd understood what they had done and what I needed to do next. So I wasn't going to reinvent the wheel or start on anything new. So when I arrived, I had my books and I had my assessments. You've got to remember this is 1993, before all of you were born, I know, but also before the internet, before we had Google Images and Google Docs and all of those wonderful things. So I went with my books and my assessments and my pictures, and I attempted to teach health and education staff how to assess and treat people with a communication disorder. And I tried to pass on my skills to them and to leave them with some hopefully culturally and appropriate resources. But when I left, that was it. I'd only worked with those few people I'd been able to work with. There was nothing sustainable. There was nothing long-term. There were no lasting really inputs other than at those 2 levels of the pyramid. I'd arrived with little understanding of how to develop systems and the need for infrastructure. And I wasn't involved in any strategic planning of the staffing levels in the ministries of health or education or of the roles of these workers. So very much, I just worked at those 2 levels. And those 2 levels are what we would say are project based. So when you're going in on a project, you kind of work on things like that. But to work at the lower levels of the pyramid, you need a program which is more, you've got more time, you've got more funding, you've got more resources. So when I was in Uganda, we did a little bit better. There was much more of a strategic approach in terms of, we had stakeholder meetings, we explored the local context, we negotiated with the ministries of health for roles and staffing, and we were warned by occupational therapists that it took them 10 years after they graduated to actually be employed by government. And we were confident that wasn't going to happen to us. We'd already thought about that, and we'd worked with health and we'd worked with education and we'd worked with local stakeholders. So we were feeling really confident. But unfortunately, pride comes before fall, and we didn't fully understand how government posts were created and, more importantly, funded. So those posts for speech and language therapists were never created by the government in Fiji. And it took us more than 10 years later, they're still not. And the little piece that people hadn't told us was that we needed to negotiate with the Ministry of Finance. So the Ministry of Finance says, yes, we will fund these posts. Then the public service creates the posts, and then health and education create the roles and the responsibilities, and then those posts are created. But without the yes from the Ministry of Finance, nothing happens. But nobody told us that at the time. It was so frustrating. So you can see how if we'd had more knowledge at the lower levels and we spent more time at the lower levels of the pyramid, I also think maybe they should have told us. They could have told us. I thought it was very mean that nobody did. But you need time. You really need to understand the local context, the local culture, the structures and the roles and the systems that there are in a country if you want to make change. So when I presented this back in Greensboro, someone suggested that they didn't like that it was a pyramid. They didn't like that it was hierarchical and that tools were at the top. They felt that tools were just as important as the culture and the context. And, what if somebody wanted to donate 1,000 hearing aids to where? To some rural province, some small island out in the middle of nowhere. So why shouldn't they donate those hearing aids? But I think you probably know the answer to that. So if we sent those hearing aids out to one of those small islands, to a community, so there's a small school. Give me a small island. I'm drawing a blank now on a small island with a small community in the Philippines. Palawan.
Palawan or...
Oh yes, I visited Palawan. Yes, definitely. Okay, so we sent those 1,000 hearing aids out to Palawan, and what would happen? Would those hearing aids be useful? Could the people use them? Why not? What do they need?
Ma'am, to begin with, I think as much as we want to donate those hearing aids to Palawan or some other smaller island in the Philippines, there would be no one who could actually help them know how to use these hearing aids. So that's it.
Now, if there was somebody, if perchance there was one audiologist somehow on that island and in that village, and he could actually show people how to use the hearing aids, what would be the next problem? What might be the next problem? What do you need? Yes, Martin.
I think the next problem is going to be troubleshooting the device at home, or the support that the families need, especially during, for example, maintenance of the hearing aids. Where will they go? What will they do in terms of those aspects or those problems that might come up with during their use in everyday life?
Excellent, well done. And then, what happens when the battery runs out in the hearing aid? How expensive are those replacement batteries in the Philippines? Are they accessible? No. So you see, giving those hearing aids, it's giving the tools, which is at the top of the pyramid, but the skills and all the resources and everything else at the lower level, it's not there. So you see, if people want to do that, they need to think about the other levels and the other things that are important and that are necessary. And that by just donating something, I mean, in Uganda, we had so many people donating toys. So, you know, people like to donate toys, books, and hearing aids, and buildings even, so they can be seen, photographed next to those things. But how useful are these things unless the children can get to the clinic where the toys are, until they can afford the batteries to keep the hearing aids working, until they have staff to measure hearing and advise how to use them, or they have money to pay for staff to work in the hospital and to pay the staff that are there. So you need to think at all of the levels for something to be sustainable. So you need to think of all the levels in the pyramid. So as I was saying, that if we look at it, when you're looking at time, when you've only got a short amount of time, you can do projects, smaller projects. But to really implement change, you need to work on bigger programs that implement all of the levels. So you need to think, you know, am I part of a project or am I part of a program? If I'm a project, I can do this and this and this, and I can't do all of these other things, and I recognize that. But if I'm part of a program, then I need to make sure that it's more sustainable. So it really is more challenging and time consuming to work on the programming lower levels of the pyramid. But these are the levels that are the drivers for sustainable change and for service improvements, which bring lasting benefits to the communities that we serve. But these are also the levels in which most SLTs and audiologists have little or no experience. I mean, what was I taught when I was at college about, you know, sustainable long-term services and policy making and decisions and, you know, budgets and funding? You know, we just don't know about that. It's important to remember that there's time needed to implement change. Now, I was in Uganda for 11 years. So that gave me some credence with my local counterparts. I wasn't just flying in and out like some people were. I was there for the long haul, but it was still hard. There's a phrase that we have in Swahili which says pole pole, which it means slowly, slowly. And that was my phrase. Every day I had to remind myself, pole pole, Maurice, slowly, slowly. You can't influence things quickly. You have to go slowly. You have to wait, and you have to do things at the pace that the community that you're working in. So another example is, when I was in Kampala, my colleagues and I were visited by a group of expatriate SLPs that wanted to come to Uganda and start a master's course. And when they arrived in Uganda, they had no idea that we were running a bachelor's program. So when they came to meet us and they said, look, we want to start this master's course. And we said, well, look, we're really struggling with this bachelor's program. It would be really good if you could help us strengthen the bachelor's program first. And then when we're ready, we can develop a master's program. But they just weren't interested. They wanted to start a master's program. So they left us. They went to the Ministry of Health. I'm assuming the minister said no. Then they went to Kenya. In Kenya, they had about 3 or 4 master's programs already. So they left Kenya and they went to Tanzania. And then they ended up in another country in sub-Saharan Africa, where they did start a program. Unfortunately, the program's no longer running, and they actually ended up stopping the program before the students had finally graduated, and the SLTs from Kenya had to step in and do the clinical placements. And to us, they've been looking at staff and infrastructure, skills and tools, and they bypassed, again, those 2 lower levels of the pyramid. They hadn't looked at the local context and culture. They hadn't looked at the roles and the systems that were in place. They just wanted to go straight in and start a program, which just wasn't appropriate. So there's lots of examples where you really need to think about all the levels. So using the capacity pyramid, it provides a holistic approach to developing sustainable services, which includes personal capacity and organizational capacity. It helps with understanding design, communication, partnerships, and grant applications. And it's not so overwhelming, as you can break it into manageable chunks. Oops, sorry. So it provides an understanding for all of those involved for the need for sustainable development and individuals and organizational capacity. And it can be broken down into manageable chunks to design an effective strategy that's not tackled bottom up or top down, but simultaneously, or in the order that's appropriate for that culture. And it's a way of communicating a feasible strategy to all involved. And it reminds us at all times of the bigger picture, not just the sector we as individuals are focused on. And it's a way to harness partnerships and to show areas of strength and weakness where support is needed to build the capacity and to work collaboratively, not just in silos. And lastly, and most importantly, when it comes to finances, using this structure can strengthen proposals, making them more compelling for funders. So funders want to see the whole picture. They want to see how capacity will be built strategically and sustainably. And it has been used in many, many grant proposals, and it's been used by WHO in the US. So those are the ways in which we feel that those are the strengths that the capacity pyramid has, and the reasons why we feel it should be used. So now let's have a look at how we can apply the pyramid to speech, language, and hearing services. So here, what we've done is we've drawn up the levels and we've drawn up the inputs at each level. So that you don't have to take in the whole thing right now. We're going to go through it level by level. But just to show you the overall picture and to remind you of the colors, how it connects with the socio-ecological model. Remember, level 1 was a local context and culture, the red. Level 2, we've got the organizations that are used that are blue. We've got the staff and infrastructure, purple, we've got the policymakers. So let's go to level 1. So paramount with all buildings is the foundation. And in our model, the foundation is consideration of the local culture and the local context or the global trends. And at this level, you're seeking information, you're gathering knowledge from people already on the ground to build a picture of the local context and culture. And it's ringed in red to show how it aligns with the socio-ecological model. It's, again, I keep doing this, sorry. My notes, I'm trying to move my notes. So it's a time to ask lots of questions and to seek information. So some of the questions that you really need to ask are, what are the languages and the dialects spoken? What are the attitudes towards people living with a disability? What access to services, education and employment do they have? What are the gender roles? What is the incidence and prevalence of communication impairment? What's the existing government strategy for people experiencing communication impairment? Is there one? What are the policies and the services that are already in place? And alongside government services, what developmental partners are already there working in the area? Can partnerships be created? Who do we want to partner with? What do we want of those partners? And at this level, it's very much the community-based participatory approach, where you seek information from those already on the ground. And all levels of the socio-ecological model need to be included in consultations. And often they're called stakeholder meetings. And you talked about, in your communities, where you talked to the community, the people in the community, what did they want? What did they need? And you worked on what they wanted and what they need. And one of you mentioned a wheelchair manual. Yeah, that's not usually what speech and language therapists do, but it's what was needed in that instance. So you ask them what they want. Any questions about that level?
Maybe you can use the yes and no buttons if you're not in a position to turn on your microphone, just so your response is a little clearer.
That's okay. That's okay. So if we move on to level 2, level 2 advocates for a full exploration of the organizational structures, the process and the systems already in place. And it aligns with the policy level on the socio-ecological model. Again, you have to ask lots of questions and really seek the answers. What education and training establishments are there? What level of training is being given and what professionals are being sent out into the field? Are there any national associations? Is there an organization to monitor accreditation and qualifications and registration of professionals? Is there a system to monitor continual professional development? Maybe there's an allied health professionals council. What processes and systems are there already in place for service delivery? Are they in health and education or both? What is the standard operating procedures, for example, for the referral process? Is it self-referral or do you need to have a medical referral to access services? So this is the level that helps you to be clear about the existing policies and the existing systems. And again, you're looking for gaps that may need attention and that may need filling. And you see, again, this aligns with the policy level on the socio-ecological model. So looking at level 3, the organizational level, it considers staff and infrastructure. We need to explore who is out there doing what and is it working? So given the incidence and prevalence rates, where are these people who are experiencing communication disorders located? Are they in rural areas? Are they in urban areas? Are they in both? What would be the optimum? What would work best? What do we ideally want service provision to look like? And don't be afraid here to think big, to be idealistic. Do we need fully qualified degree holding SLPs, specialists in their field? And where will these be based? What will they need to work? What other staff do we want? Do we need only degree holding specialists? Or how about village health workers or community-based rehabilitation professionals or multi-skilled aides? Do we want an institution or a community-based service? Do we want both? Will it be health? Will it be education? Again, will it be both? So where do we start? So once we have an idea of the type of professionals or we know the prevalence and incidence rates, we could start looking at numbers and plan how many we need to slot into those systems. So we need to look at the infrastructure that's already in place and what will be needed to support any of these staff, excuse me, that we put out there in the field. What do we need to provide them so we can enable them to function efficiently and effectively? Things like workspace, power, water, transport. Who's going to pay for it all? How's it going to be maintained? Excuse me. Vocal cords getting very, very dry there. So if we move to level 4, that considers the knowledge and the skills, which is easier to understand. What knowledge and skills do staff need to work efficiently and effectively? And are they prepared? Are we preparing them to do what we're asking them to do? So we need to examine our training establishments and the programs, which are actually situated at level 2. Those are those organizations. And as mentioned earlier, for development of audiology and SLT services, excuse me, we need professionals who have certain skills as well as their professional clinical skills. They need to be able to conduct research and audit. They need to be able to advocate for people with a communication disorder. They need to work as part of a team. They need to be able to teach and train and transfer skills. They need to be able to supervise and support students, colleagues, and other professionals who can also work at policy levels and at public health planning. There needs to be a system in place for CPD to maintain the quality of services. Again, we're asking an awful lot of these professionals. So one of the things that we did in Uganda, I was very concerned when our students were graduating, how are we going to support them? And so we started what was a mentoring program. We managed to get funding from an organization in England to run a CPD mentoring program. So the graduates were brought back to Kampala twice a year to attend training, a 5-day in-service training, where we worked on various skills. And we asked them, what do you need to know about? And they would say, we need to know more about dysphagia. We need to know more about autism. We need to know more about alternative and augmentative communication. We'd like to know more about doing clinical audit. So we structured the workshops depending on what their needs were. And we brought in professionals from all over the world. But one of the important things that we really worked on was peer mentoring. So each of the graduates was linked with a speech pathologist somewhere in the world who had experience working in a low resource setting. And they could contact each other by Skype or by email, and they could share resources, they could ask questions, they could help each other. And the other thing that we did was we really pushed for peer mentoring within Uganda. So we really encouraged the graduates to talk to each other, to see cases together, to run their own in-service, to read articles and then discuss them together. So really very much peer support, peer development, and that's going really well. We now have a WhatsApp group. We started off with a WhatsApp group for the Ugandan therapists, and now they've got therapists in Kenya, Tanzania, South Africa, and those who have gone around the world. And you see these long messages in WhatsApp where somebody will say, I've got a patient that's got X, Y, and Z problems, and I'm just not sure what to do with them. Has anybody got any experience? And then you'll see this whole flurry of responses where people are saying, have you tried this? Have you tried this? I tried this. Look at this article. Look at this resource. And so that mentoring is continuing. And so that's something that started out very small. The money ran out. We couldn't continue it beyond 4 years. But the effects of that have been long-lasting and sustainable. So that's level 4, and then level 5. Yes.
Why did it need money? Because you were paying the mentors?
So the people who were running it and organizing it were coming in from overseas.
Oh, they were flying in.
Mm-hmm. But
Okay.
also then we had to bring the therapists to Kampala. So we had to pay for their travel to Kampala. We had to pay for some of them for accommodation and for food. They always wanted so much food. So that was what, there weren't enough therapists in Kampala to run the degree program and to run the training and everything all at once. So that's why we got the funding to do that.
Yeah, all right. Because when you said it was a WhatsApp group, I'm like, that doesn't cost too much, a WhatsApp group.
Yeah, so that's why it did, because we brought in specialists, you know, that really knew. So, you know, we had Mershan, that's where I first met Mershan Pillay. He came up from South Africa to run a workshop on dysphagia. I mean, it was a really, really good workshop on dysphagia training. We had people who were experts in AAC. So we brought in experts to do the training. It was a luxury. It was very nice. And it did work. Yeah, it did. It was a good program. So then looking at the last level, level 5, you know, these professionals, they need access to tools of the trade. They need laptops, iPads, audiometers, a supply of hearing aids and batteries. They need culturally and linguistically appropriate assessments and therapy materials. And this is where the donors itching to spend their money into data equipment, they can be tapped. So, you know, this is where you can use those donor funds, and those donors say, okay, you want to donate things, but these are the things that we really need here. These are the things that will work, you know, not just anything you want to get rid of. So there you have it. Those are the 5 levels. Those are how they work. It's a lot, you know, it really is a lot. And I really don't expect you to understand it all now. You know, I've been years and years and years working in the field. I've been years and years and years working in, you know, this area of development and in low and middle income countries. So it is a lot to take in. So pole, file it away for when you go out, and refer to it every now and then. So just summing it up, you know, we advocate for the use of many public health approaches in conjunction with the pyramid, especially those mentioned earlier in the presentation. And they all emphasize community participatory approaches that involves all of the stakeholders in the discussions, understanding from stakeholders what's needed, what's wanted, and how they think it will work best. And we're always striving for equitable, innovative, and efficient population-based services. The capacity pyramid is a strategic approach to plan, manage the gathering of all of this information, to plan, develop, and build sustainable services. And I just wanted to share an excellent example of a program that I was really lucky to be involved in when I was in Fiji. So in Fiji, there was a physio that was employed by Save the Children Fund to provide services for the disabled children in Fiji. She was a wonderful lady called Rosie. And she set up a training program for community rehabilitation assistants. Now, these were multi-skilled therapists from and working in the local community. So she started at level 1. She explored the local culture, the context, and the government attitudes and provision. She found that Fiji, being a country comprised of 300 islands and only 750,000 people, they needed services that were provided locally. People in Fiji are very, very friendly, but they like and they trust the familiar face and the familiar accent the most. So they needed local people to be involved. Now, there was a really good system of local clinics and a hospital in each district. So Rosie worked with the government to create the post of CRA that would be based in each of the 7 district health centers. There would be one CRA that was recruited from that local area that was going to be employed in that local clinic.
Sorry, please remind me, what's a CRA?
Community Rehabilitation Assistant. A community-based rehabilitation worker, but they were called CRAs there. So they were brought to Suva, the capital, for a 6-month intensive training program. And they were trained in PT, OT, and SLT. And then they were sent back to their homes to go out with those health teams to the villages to identify and work with families having any family member that was disabled. Now, in those days, children who were disabled were often hidden away at home, and they weren't really brought out. They weren't talked about. You know, it was a disgrace. to have a disabled child. So they were hidden away. And it was only by going into those communities, building trust, building a relationship with those communities, that they were trusted and they gained access. So somebody would say, actually, you know, that house there, they have a child there that's disabled that could really do with your help. Next week when you come, I'll try and tell the mum to bring the child out. Okay, so you're going in, the community gatekeepers, you're gaining access, you're being trusted, and you're given input. So when I arrived, this network of community rehabilitation assistants was really well set up. And my role was to go out and visit with each one of them and work with each one of them, going out in the community, seeing any cases they had that they were struggling with in terms of communication. So I worked with them, you know, upgrading their speech and language therapy skills. And it was a fabulous opportunity. You know, finally, I found I was involved in a sustainable and effective program that had worked, you know, through the levels of the pyramid, that was sustainable. And the CRAs, they kept records of all the individuals that they were seeing. Before we talked about clinical audit, they had all of that clinical audit information that they could present to the Ministry of Health to say, look, we've got this many disabled people and this many disabled people here. We need services. And Vani was the CRA that worked in my hometown in Lautoka. And Barney actually went on to run the program. She became the head of the CRA program. She trained more CRAs. She then went on to do her master's in public health and ended up working in the Ministry of Health in the planning unit. And actually, I think she ended up emigrating to New Zealand because her daughter moved there. But it was a very, very successful program. And I thought, fabulous, this is what happens everywhere. This is, you know, this is really good. And, you know, when I left Fiji and I went to the Philippines and I went to India and I went to Uganda, I'm like, why don't you have a CRA program? Why aren't you doing this? To me, it was like, it's so obvious, but it just hasn't taken on. You know, in India, they have multi-skilled therapists, but there's not many countries that do. So it's yeah, I was very lucky to be involved in that and to see, you know, at that time, I didn't realize, you know, it's going through all the levels of the pyramid, but looking back on it, I can see how, you know, it was.
I think we never brought you to visit our community-based rehab program.
Sorry?
It sounds like we never took you to visit our community-based rehab program.
I did once.
The one in,
Yeah, we did. We went to one in Manila, and it was amazing. But it's very small, isn't it? So I'm like, why can't we replicate that? Why couldn't you do that on a bigger scale? Why can't you do that in other cities in the Philippines, not just in Manila? Why can't we have more PT, OT, SLT collaboration and working? Why do we have to have PTs, OTs, SLTs working in silos? Why can't we have multi-skilled aides? Why do we have to have degree holding? Why does everybody have to get a degree? You know, to work in the community and to work, you know, we could empower people with minimal training. This was a 6-month training course. They didn't have a degree, they didn't have a diploma, but they were doing amazing work in the communities. So many kids were receiving so much care. The communities were learning so much about what they could do for these children and adults. They worked with adults as well. And I just thought, you know, it's, you know, those 20 dysphagia trained therapists or those 1,000 community rehabilitation workers. That's what we mean by a population-based approach. It's working away from the specialist care to providing a kind of a lower level of care, but a lower level of care that reaches a wider segment of the population. So these are the things that you need to think about. You know, this is what you need to think about in terms of providing services in the country. What is the demand? Is the demand for fully trained, you know, PTs, OTs, and SLTs? Or is it, would the communities be happier with community workers that have a little bit of knowledge? I don't know, you know, you have to think about these things, and you have to work on these things in your countries and in your communities, and decide, you know, going forward, you know, you can do yourselves out of a job. You know, it can be, you can, you know, you can do yourself out of the need for a fully qualified speech and language therapist. And that's what happens. People, they want the power, they want to be the one that's in charge, that's dealing with all of this. They don't want to let go. Do you have speech therapy assistants in the Philippines?
No, but our entry level is at the bachelor's level.
Right, but our
after a
entry level.
bachelor's. So, I mean, that would mean speech therapy assistants would either be graduates of other programs that were given a little bit of training, you know, psychology or accounting or something, given a little bit of training, or that they're high school graduates that are given a little bit of training, which is more what was happening, I think, in the community-based program. And the difficulty, I think, was that the community-based rehab workers were also municipal health workers. So they weren't only trying to do OTPTSP things, they were doing all the other things that a municipal health, all other health things. And they were, I mean, you're right, it was an infrastructure problem because all they were given was a little allowance and not really a stable, they were given many tasks and then a little allowance. And one of the concerns was quality of work, quality of care. This is what you were saying, and that they didn't have regular access to somebody more trained that they could consult with, and who could
Yes.
be ultimately professionally responsible for the assessment and intervention.
Yeah, so if you go back to the pyramid, you're not giving them enough resources, but you're not giving them enough knowledge and skills, and you're not giving them enough support from other staff and infrastructure. So you see 3 levels up here that's you can identify the problem, so you can see where the problem is, and you know, you need to go in and give them more resources, you need to give them more skills, and you need to provide them with more support from fully qualified and trained people. Yeah, it's very tricky. I mean, when they tried to introduce speech therapy assistants in England, there was a big pushback. You know, speech therapists were like, you know, they can't possibly do what we do. And it's like, no, they can't. Of course they can't, but that's not what we're asking them to do. So, you know, in the UK, speech therapy assistants would work in a school. So have you done work with kids on articulation problems? Yeah, so you know that if a child has an artic problem, you have to assess them. You have to find out what the problem is. Then you have to target what sounds you're going to work on. But then once you've done that, you develop a program, and that child has to do that program every day for a certain number of minutes a day, 5 days a week, right? Now, you don't need to be doing that with that child. That's where your speech therapy assistant comes in, and you say to the speech therapy assistant, this is the program. I want you to go through these activities with this child every day. 15 minutes a day in the morning and 15 in the afternoon. Pull the child out in class, work with them, and do that 5 times a day. You're giving them the materials, you're giving them the resources, you're giving them the skills and the knowledge to do that. But you're not asking them to assess, you're not asking them to plan, you're not asking them to develop the program. And then you don't have to do that. You don't have to spend your time on those boring drills. I used to hate them. You know? So if they're used wisely and carefully, they can free you up to do more assessments and to write more programs. And so then more children are getting help, and you've got assistants being employed, you've got speech therapists being employed. Nobody's doing anybody out of a job, but you're working together. And that assistant could be doing PT exercises at the same time. You know, they could also be involved in doing PT exercises and language development tasks with the client. So, you know, you can see how there's cross-sector working. There's no right and wrong answer. You've just got to find what works best. So I've got 2 more slides. What is the time? Ooh, it's late. So hopefully the presentation will have helped you to clarify in your mind what I mean by public health models and capacity building and population-based approach. As audiologists and SLTs, we recognize that technical skills are vital, but for effective advocacy for service development in LMIC is almost as important. We need to have a knowledge of public health approaches, understanding of different capacities at the individual and organizational level, and how they're related and they build on each other. And we need to be able to systematically plan and communicate that plan with the government, with development partners, and with other stakeholders. So using the capacity pyramid can help you think through all the important capacities. It can identify where there are gaps, and it can advocate for effectively filling those gaps with various funders or organizations, both government and non-government. So we really can and should do more than just be researchers and service deliverers. As SLTs, we have very useful practical knowledge from the field to contribute. Our input can ensure that services developed for people experiencing a communication disorder are developed in collaboration with those people. And that results in a more effective, accessible, and sustainable service. And so, at ASHA, my, final recommendations were that we really need to promote creativity and innovation in the minds of speech, language, and hearing professionals and health service providers. Training institutions need to develop training for speech, language, hearing professionals that furnishes them with appropriate skill set for working in low resource and low income settings, and maybe not necessarily might not be degree holding SLPs and audiologists. And by applying socio-ecological model principles and a community-based participatory approach, we really can develop and plan equitable population-based speech, language, and hearing services for people experiencing a communication disorder. And by using the capacity pyramid, we can together strategically build sustainable services. So if we go back to that little Sankofa friend of mine, we really need to remember the gems from the past and incorporate them with the knowledge from the new, and not try and reinvent the wheel the whole time. So those are some references. And at the end of the slide, I put in some extra slides there with a little bit more knowledge, a little more information on those other public health approaches that you might find useful. So that's it. That's a lot, I know. What questions do you have? What maybe, if there's something that you didn't understand and you want me to explain it more, or if you're thinking that's never going to work, what about this, and this? Let's talk about it.
Or anything that struck you most from the whole talk, the whole presentation, while you're thinking about what you want to say or ask, say to Maurice or ask her. Maurice, I need to mention, I talked about an Indonesian developed therapy material, but there are a handful of speech pathologists locally that are also working on developing materials and making them accessible to the public. Yeah. So it may be that most of those are online materials because of the pandemic, but there are also some that they're creating little games using local context and things like this.
And that's what's so important to do, is to share those resources and share those materials. Everybody's doing it, and you do it, but you need to share them. And with the internet and with online resources, you can upload things and share them so much more easily than back in the day when I went out to Fiji, when we posted things to each other.
You mailed them.
Yeah, we mailed them, and we didn't have photocopying. We had, so the amount of time I used to spend photocopying, cutting out, laminating, preparing materials. Now when I see Google Docs and Google Images, and I'm like, oh, whoa, I can just download all of these images and just, you know, so easy to just laminate them and find exactly what I want. I can, you know, Google Ugandan boy climbing palm tree, and I can find a picture of a Ugandan boy climbing a palm tree, and I've got one, you know, for coconut tree climbing boy. It's all there. It's all great. It's so easy.
Okay, so do you have anything to ask or to say?
No po, ma'am. I think I would like to share something lang po about what struck me the most during during the presentation po. So I am the one po who shared that I had an experience with wheelchair manual making. So I think this is the closest experience I had with the community, and I think it is also one of the experiences that I would treasure the most, because at first I thought that this simple activity, so it's called like a think aloud activity, wherein you would get opinions from the actual wheelchair users. So at first, while we're working with a wheelchair manual, we're just inputting, or we're just putting a lot of information, and then our clinical supervisors would say, do you think they would read that? Do you think it would be helpful for them? Then we would think na parang we would think na yeah, it would not be helpful, but for us it would be. So we're looking in a clinician perspective. We're not looking into how the community would receive it or how would the community understand it. And then upon presenting the actual manual to the actual wheelchair caregiver and user, so we were given a lot of input that this part is the most essential, this part is what they needed the most. So upon that, with that experience, we knew that how important it is to check on the community before doing the actual tool. So in here, I think the problem with that experience is the problem that I encountered in that experience is that highlighted in the presentation, that we already have the resources. We have the wheelchair, we have the manuals, but we jumped into the other levels. That's why it's more difficult for us to disseminate such materials. But I think what is important is that we were able to learn from that experience, and then we were right now I was able to determine what other levels are important to consider when it comes to such activities po.
That's lovely, Ella. That's really perfect. So you can see that you're not working at the policy level, you're not working at the organizational structures, but you went in and you looked at the local context and the local culture and what was happening and what was needed. And then you went up to fill the gap, you know, up at level 5, the resources. They needed the manual. And so, you know, you were working, there was a gap there, and you filled that gap. There was a gap, it was a need, and you filled that gap. But you also looked at the local context and culture to provide something that was suitable and appropriate for them. So that's a perfect example of how you use the pyramid. Well done. That's really nice. I will remember that one. I might use that in another presentation. And that's what somebody asked last time. They said, there's so much, how can we do all of this? And I'm like, no, you don't have to do it all. You know, you don't have to do it all. You identify that gap that you can fill. Okay, I can fill this gap here. I can do this. I'll take into account these things and I will just work at this level. Any other questions or observations? Is there any parts of it that didn't make sense, or any parts of it where you think, yes, you know, that's, you know, you've got another example of an experience that you've had that fits with the pyramid?
I think I can share some experiences with regards to culture and context in the Philippines. It's really important to understand that sometimes early intervention isn't all that prevalent in the Philippines because of the culture where, sorry if it's noisy, where it's the culture in the Philippines where we tend to coddle the children that really, and I think with regards to like they don't really need to speak for themselves if they so much as whine whatever they want or they need will be provided for them. And even with telltale signs or red flags with regards to development, I've had personal experiences with my family where a child has been is like a little bit older but still hasn't been talking much, but they really do try to push it as far back as needed. Usually intervention happens at school level or preschool, where educators or teachers would let or notify the parents, this little one isn't as performing as well as his or her peers. And I think that's important with regards to culture here in the Philippines. It's really trying to understand that we do oftentimes have to write in the reports late intervention and so much and so forth. And it's sometimes you think that it's as simple as, oh, the parents could have this neglectful, but really it's all in the culture. And I maybe that's it's not that prevalent in some cultures, maybe in Eurocentric cultures and all that. But I do think that's really important because it's really prevalent in a lot of the cases that we've handled. And it's important that, as mentioned before, that at the community level on prevention, it's that we try to acknowledge or address that. But even sometimes with those programs or projects that we're trying to educate the mothers on what signs that their child could be presenting with that are sort of red flags, sometimes they tend to forget that even like right after the program, it's live and forget. And it's really difficult trying to close that gap or trying to address that because it's very attitudinal. A lot of the barriers in the Philippines are not just financial or physical, but it's really attitudinal. And trying to address that would really need to address all the five levels that you've discussed just now. And I'd like to add this is a different topic altogether. With regards to SLP assistance here in the Philippines, it's really difficult to try and implement that as of the moment because with regards to where will we be placing these SLP assistants? You've mentioned pulling out the child out of class for 15 minutes a day. SLP practice here in the Philippines isn't all that established yet because we don't have SLPs much practicing in schools, even if there is a few because we've had a survey released in 2020 that indicate that there are some speech pathologists, though they're not many, they're just a few practicing in schools. It's most likely that they're practicing in private schools or sped schools, while a lot of, especially during the pandemic, a lot of children have shifted to the public school setting, where in the public school setting here in the Philippines, not only are teachers alone are underpaid or undercompensated. So it's really difficult trying to, and there are not many or there are no positions at all to be filled up by SOPs in the public school setting. So it's a bit difficult, but a good it's a good solution or a suggestion to take into consideration, considering that there are only 4 universities in the Philippines. 3 of them are mostly clustered in the main islands of Luzon. There's one in Visayas and none at all in the last island, Mindanao. So that's really a concern that could be addressed through the use of SOP assistance, but the building blocks to get there, I guess we still need to address that. And I think we are trying to, because with the release of the SOP Bill Act here, which mandates practice in the Philippines, it monitors and mandates practice. And with also recently we were discussing this the other day, there is a recently approved and signed bill that indicates more inclusive education here in the Philippines, where instead of sped schools, we would have inclusive learning centers here in the Philippines. Maybe then, in those sort of contexts in the Philippines or work settings, maybe we can include, instead of having SOPs actually work in those inclusive learning centers, we could include instead the assistants. And I think it's really eye-opening being able to listen to you speak today, ma'am. Thank you.
Thank you, Jean. So, Jean, I mean, the Philippines is a huge issue because you are a multi-island nation with sort of middle income, low to middle income, and high income areas. And the way you're talking about it, I hear you. What I hear is that you're looking at, not you in particular, but people in particular looking at what's being provided in the US, what's being provided in the West and in Europe, and we're going to try and provide the same thing here in the Philippines. So you're starting off with your degree courses. Now you've got SPED schools. So like when I was training, when I was working in England, we had special ed schools and we had speech and language therapists working in mainstream schools, working in SPED schools and working in health centers. We didn't have any working in mainstream schools. They were all employed by health. And they did away with all the SPED schools and they went to inclusive education. So all the kids were then put into inclusive education, but speech and language therapists and physios were employed by health. They weren't employed by education. So education then had to pay for them from health to come and work in the schools, but they didn't want to pay, or they didn't pay as much as they should. So those kids that were getting all of this help in the SPED school were then in inclusive education, which is wonderful, but they weren't getting the help that they needed because the resources weren't there. So it was a real catch-22. So, we all talk about inclusive education being the thing we should aim for, but it's the only thing that we should aim for if we've got the structures, the staff, the infrastructure, the resources, the attitudes in place to make it successful. So you can't just move to inclusive education without tackling those things. So then when looking at the Philippines, you have to decide in the Philippines, what do we need? Okay, so you're saying, okay, maybe we need a degree, we need a university in Mindanao to produce speech and language therapists over there, degree holding speech and language therapists. Now that's a really expensive way to provide help. Is that the best way for Mindanao? Is that what Mindanao needs right now? I mean, I never went to Mindanao, so I don't know what it needs. But, I know that, in Fiji, we didn't need a degree course. Rosie was there and she was like, no, we don't need a degree course here. We don't need a whole load of degree holding speech and language therapists. We're going to go in at this level and we're going to start with community rehabilitation assistants at a lower level. And so she was really visionary and she really thought about it and said to them, no, don't do this. And so I got a message from a university in Zambia. Somebody contacted me from Zambia and said, oh, I heard that you were working in Uganda. We really want to start a degree course in Zambia. And I said to them, well, that's really interesting. And, I'd be very happy to share my experiences in Uganda. I said, but, have you thought about, what is the best provision for Zambia right now? Have you considered training special education teachers? Have you considered using, maybe diploma holders or community rehabilitation assistants or something like that? And talked about the other ways of approaching the problem. And he listened politely, and then I never heard back from him again. And another friend of mine who's a Zambian speech and language therapist said, yeah, he called me and we had the same conversation and I haven't heard back from him either again. And I've heard that they've started the degree course, or they are starting the degree course in Zambia. He was just fixed. He had this colonial educated mindset that this is what they do in the West, and this is what we're going to do in Zambia. We're going to copy that. So all I'm saying is there isn't necessarily a right way and a wrong way, but you need to have considered all the ways to choose the way that's right for you. So don't just automatically think we need to start more degree courses. And yes, maybe, you do need them, and maybe that would help, but also think about what else can you do as well. Because if you think about the supply and the demand, to supply that many fully qualified speech and language therapists to meet that demand is going to take an awful long time. I think somebody did the maths and it was something like, I don't know, something like 20, no, I think it was 21 something. We would have enough speech and language therapists in Africa to come to the same level as what we've got in Europe right now.
21 something as in another century.
Yes. If we were producing this many speech therapists a year, to get that ratio of SLP to patient population right down, it would just be, we'd be going into the next century. So it's just, you have to, don't be blinkered in your thinking. Really be creative, be innovative, and consider what will work best. Set aside the power and the kudos and the titles, and think about, we've just written an article about centering the person with a communication disorder. They are front and center. What do they need to go about their daily life, to have a good quality of life? What do they need, and how can we provide that? And is it by starting more degree courses? Is it by assistants? Is it by community workers? Is it by more early intervention and early education? Is it maybe working more with special education? I don't know what the answer is, but I'm just saying you need to consider all of them, and don't be blinkered into thinking the only way forward is degree holding speech and language therapists. Any other thoughts, questions, concerns? And you are very free to disagree with me,
Hello, ma'am. I just have this thought about the role of social media, or the use of social media, in terms of like program planning, or in terms of the levels. So I was thinking, where do you think the social media can be more appropriate? Is it on the level 5, on the resources, or on the knowledge, skills, attitudes? Because or is it depending on how do we plan on utilizing the social media? Since here in the Philippines, or perhaps globally, the role of social media is really prevalent enough to influence people, enough to spread awareness, or do things such as educating and things like that.
I think you've answered your question, Martin. You can use social media in every level of the pyramid. So you can use social media in exploring the local culture and the local context and global trends. You can use it as a resource. There are lots of apps out there for working on speech and language. You can use it to, it was used for the Arab Spring. Talk about regime change. So if you want to lobby government and lobby, create awareness and advocacy, you can use social media to do that. If it can topple a government, it can really be used to gain awareness and support for something. It can be used as a training tool for training your level 4, for training skills. You can have workshops, you can have training manuals developed and delivered over the phone. You can go through training as an app on a phone. So really, social media can be used at all of those levels. It just depends on how you want to use it and how you can use it. Does that make sense? Social media is the future. There's no getting away from it. Joyce and I were all born before social media, so I don't know about Joyce, but we're not very adept at it. But you guys are a completely different generation. You've grown up with those thumbs being able to, I still remember Joyce, Nats, being in the car with Nats. And I didn't have a cell phone, but Nats had a cell phone, and Nats is driving and texting, at the same time. And I'm like, whoa,
No, I
that
think
is
and
a skill.
texting and her keypad was all worn out, so you would have no idea what key she was pressing, but she knew what key she was pressing.
Yes, that was it. I remember you couldn't see the letters on the keypad anymore. And I didn't even have a cell phone in those days. She was streets ahead of me. So, you know, you can use social media so much more better than we can. I was just deciding today, there was something came into my inbox about something on, they were going to do a webinar on Twitter. And I'm like, oh no, I don't have a Twitter account. I can only access, it was a free textbook and a free webinar, but I could only access it if I had a Twitter handle. And I'm like, how's this going to work? I don't know what Twitter really is. I thought tweets were 159 characters. How are they going to do this thing on Twitter? So I was asking my friend, what do I do? So, you know, I'm going to have to get a Twitter account if I want to get involved in this. You know, the WhatsApp that I have with the students in sub-Saharan Africa, it's absolutely fabulous. It's just revolutionized our communication and sending the materials and answering questions and providing support. And teletherapy, have you guys been using teletherapy during COVID? I'm sure you have. I mean, it's changed the face of therapy now. You know, you don't have to travel to see a therapist. You can just hop on Zoom and you can have a consultation. Everything's different. Everything's changed. I mean, I'm talking to you. I'm teaching you in Manila. You know, I'm here in Greensboro, North Carolina. You know, do we need universities anymore? Can we do it all virtually? It's the future. It's different. Social media and technology is just taken over our lives. And some ways it's good and some ways it's bad. So you just have to embrace it and use it to your advantage.
Is she?
Ma'am, and this is in relation to how we can ask or tap people from our community. Um, as what Jean mentioned before, I think she mentioned that we worked on the same service program in our CBR rotation. We were working for Kaisaka, and we worked on understanding more of their history, how
Kaisaka is an NGO.
yes, it's an
That
NGO of and we worked under this um sub committee or faction of mothers. It was called Mother to Mother approach, and they actually started off by um going to clinics and observing how therapists would give um, intervention to their children and ask, and then they talked amongst themselves and they thought now, oh, I think we should talk amongst ourselves about how we can implement this in a way that it will help our children at home. It could help more mothers that we possibly know in our community. So they went around and they um, did an ocular of other mothers who shared the same experience, share the same sentiments, and they eventually formed an organization that helps the mothers on how to provide intervention to their children at home. And then now they're actually kind of a big organization already. They also sponsor special education classes and other PT, and I think that's one of the things that uh I could remember as you were saying, as you were discussing a while ago, that we don't have to establish, we have to start somewhere, not just only our in our profession, not just only those that have degrees or graduated from different courses, but we can also start from the community. After all, they know much more about what they want and what they need than us. And it's hard to impose what we actually want for them. And it's up to them to decide what they actually want for their children. So that's one of my key takeaways. And I think that's really fitting that it's actually nice how good their organization is right now. So that's it, memories.
That's lovely, She. That's really nice. So you see, I mean, so I talked about Karen Wiley earlier. So on the one hand, Karen Wiley is one of my mentors, and Karen Wiley fully believes that, you know, the grassroots level, you can go in at the grassroots level, you can provide services at that level, and then you can push up from the grassroots level, you can push for policy change and you can lobby government for change, and that you can make a huge impact at that level with lasting change. Then my husband is at the other end. He believes that you have to go into the government. He thinks you need money, you need government. He believes that you need to work with the government. The government needs to make a strategic plan to develop services, and it needs to consider all of those levels from the degree holders down to the NGOs, and it needs to collaborate and partner with those. But he approaches it from a top down, and Karen approaches it from a bottom up, and they're both right. You know, they both have their strengths and they both have their places, but it's you know, it's what's necessary at the time. And you know, as you are coming out, you know, initially you could have much bigger impact at the grassroots level than at the policy level. You know, let's face it, who's going to listen to a newly qualified speech therapist that looks about 15 anyway? I mean, I used to get that all the time. You're not old enough to be a speech therapist. They would always ask me, are you a student? And I'm like, no, I'm fully qualified. But we don't have the tools when we graduate to understand how to lobby government and how to work at those higher policy levels. So we do what we can at maybe the grassroots level, but as you get further down the line, I mean, I graduated in 1989. So, you know, I've worked through therapy, I've worked through working in schools, in hospitals, in communities, in those levels, and now I feel that I'm ready to try and tackle some of those higher levels. So one of this year at Asher, I've just been finishing an abstract. So I'm trying to develop a talk.
Because they are due on April 6th.
I know they're due on April 6th. I'm not ready yet. I've got 3 I'm thinking about.
Ooh.
I figured if I'm going to do it, I might as well do 3, you know, in for penny, in for pound. So, but the main one that I'm working on is using the capacity pyramid to explain to US universities how they can get involved, or if US universities are going to get involved in a low or middle income country, how they need to look at all the levels in the pyramid before they step in. So US universities have a habit of wanting to start degree courses everywhere, master's degree courses even, not bachelor's, has to be a master's. And so I'm like, well, hold on a minute. Before you do that, let's just have a look at the local context, look at the local culture, look at who's working. Because they come in thinking the only way to help a person with a communication disorder is by putting a speech therapist there. But as Ishi says, you know, those mothers, mother to mother, you know, those mothers can do something. And if they had the training from the university, empowering them, giving them the skills, you know, you've got 60 mothers working with 60 other mothers who are working with 300 children between them for the same cost of, you know, 1 workshop with 5 speech therapists. So that's, you know, I'm trying to get them to think before they step in, and to try and think about what's best for the local culture and the local community. Don't impose your views. Think about what they want. Listen to the stakeholders, because they're really not very good at listening sometimes.
And maybe what are the cultural competence skills their students would need before, like, being deployed to another country
Yeah, so Shisomo, who I'm working with also, we're going to do another one. The other one I want to do is a fun one, is, you know, what's it really like working overseas? So, you know, we run these courses on cultural linguistic diversity and cultural humility and cultural awareness and all of that. But actually, once you get there, it's how do I survive on no money? How do I survive when the water goes and the electricity goes and the person refuses to speak to me because I'm a woman, or I'm a white woman, or I'm an unmarried woman, or, what do I do when I fall down a manhole because they've taken the covers off and there was a flood? How do I access, healthcare? How do I get repatriated if I have a problem? So we wanted to do a light-hearted.
What do I do when my cell phone gets pulled out of my hand in the middle of the street?
Exactly. Yeah. How do I walk down the street? So I had a colleague of mine. She's 6 foot. She was 6 foot and blonde, and we used to work together. So she was called the tall, fair one, and I was called the short, dark one because I'm only 5'1". I'm your guys' height. I loved being in the Philippines. I was a normal height person. Everywhere else I'm considered short, but in the Philippines I'm like, yay, I'm a normal height person. Anyway, she was walking down the road. She'd just come back from exercising somewhere, and this guy on a motorbike comes by, jumps off his bike and starts pulling at her bag. And she's like, hold on a minute, this is my bag, and she's pulling back. So the two of them are pulling at this bag, and they both let go at the same time, and she falls over. And he's like, oh, I'm so sorry, are you okay? And she's like, you're trying to steal my bag, and now you're apologizing? Because culturally, they're very polite in Uganda. They're going to rob you, but they're going to apologize for robbing you at the same time. And she said, and I thought about it, and it was just sweaty gym gear. Why was I holding on to this bag so tightly? I could have been really hurt. And things like that. How do you deal with that? How do you walk along the road so that they're not tempted to whip your bag off your shoulder? So anyway, so we wanted to do something like that, a little bit more lighthearted and a little bit more fun and a little bit more practical than that. So we'll see if we get that abstract written and submitted in time.
Or even if there are local people working there, how do I mix in without getting the backup? Without offending them in some way, just by saying the wrong thing.
Yes, so I can tell you another story. I have so many stories. That's why they said you should do this, Marie. So I'm in Fiji, right? So I've just arrived. I'm in Fiji, and there's a big workshop on disability. And there's another volunteer there who I had to live with. She was my housemate. She was, at that point in time, it sounds terrible, but she was a 55-year-old divorced mother of 4 boys, vegan, right? Okay. So now I'm a single Catholic 20-something-year-old meat-eating person, and I'm sent to live with this woman who is exactly the same age as my mother, who I just left because I wanted to go and explore the world and be independent. So I'm sent to live with this woman. But anyway, we're at this workshop, and naturally, as often happens, they're talking and they're complaining about foreigners coming in with their ideas and their ways and pushing us around and thinking they know better. Right? They're saying this in front of us, and I'm like, yeah. That's true. That happens. I agree. And then this woman stands up and she says, I've been sitting here and listening to all of you, and I would just like to let you know that Maurice and I'm like, leave me out of this, please. We gave up very well-paid jobs in England to come here and to do our bit for the disabled population in Fiji. And it's disheartening to hear you speaking like this. And I'm like, no, I gave up a really poorly paid job in England because I wanted to come to Fiji because it was exciting and beautiful and you've got good beaches. I didn't have any altruistic motives at all. But she said that. She stood up and she said that, and she included me in it. And it was so embarrassing. And I'm like, that is not the way to get into the local organizations and to be accepted.
Yeah. So, I mean, here, maybe it's not somebody from outside of the country coming in, but here we are, UP students, UP graduates, and then we walk into a barangay somewhere, and we can have the same effect,
Yeah.
I have come here educated almighty. for you to
Yeah,
uplift
and
your
it is.
status. It's like,
It's all perspectives. It's all to do with perspectives. And Ella, you touched on that. You know, you were looking at the manual from your perspective, but you needed to be able to look at it from the user's perspective. And this is, you know, we do this in cultural classes. You know, you try and get people to look, you know, you have to be aware that you're looking through a particular lens and that other people are looking through different lenses. And you've got to be able to change those lenses. You've got to be able to put yourselves, you can't put them fully in somebody else's shoes, but you can try and walk in those shoes and see what it is that their life is like and what they need, not what you think they need. And it's hard and it takes years of experience. And you still, you know, never get it right completely. But as long as you're aware that, you know, you're trying to do that, then, you know, people will accept you. But yeah, pole pole, as they say, slowly, slowly. It fits for everything, pole pole. It solves all problems.
all right, Maurice, it's getting close to midnight for you.
Yes, it is.
So thank you so much for sharing your evening with us.